Good afternoon. I want to thank Sages for giving me this opportunity to present our data. So in the United States, about 1 million people, there are about 1 million colon resections done yearly. And this is for a variety of pathologies that range from diverticular disease to colon cancers. A significant portion of these colon resections are actually performed for benign polyps. These are typically patients that are referred to the general surgeon or the colorectal surgeon by the gastroenterologist after a failed polypectomy for several reasons. And some of the reasons that these patients are referred includes inability to access the polyp, probably due to location, and also the size of the polyp. There's also complexity of the polyps. Most of the times the sessile polyps are very difficult to resect, and the gastroenterologist are worried about perforation. So these patients then end up in a general surgeon's office or a colorectal surgeon. So the question that arises from this is that all those patients that are referred to the general surgeon, do they really need colectomy, those patients that are referred for benign disease? Well, this has actually been looked at by some investigators. For example, Church from the Cleveland Clinic looked at 58 patients that were referred for resection for benign disease. And out of those 58 patients on repeat colonoscopy, 48 of them actually have a successful endoscopic polypectomy. Villoyanes, also in Texas, looked at 252 patients that were referred, again, for benign polyp disease for resection. Well, he actually conducted a repeat colonoscopy for 172 of them. And out of those patients, 58% of them had a successful polypectomy done. Now, despite aggressive attempts by even an experienced surgical endoscopist, there are actually patients that you still can't perform a colonoscopic polypectomism. Now, the question we have is, does laparoscopy actually help in assisting the surgeon in performing this procedure? This, again, has been looked at. Smith from Sweden actually described in 1997 two patients of his that he used intraoperative laparoscopy. He used laparoscopy to perform intraoperative colonoscopic polypectomy. And Morris Franklin in Texas, again, reviewed 110 patients of his underwent a laparoscopically monitored colonoscopic polypectomy. So again, laparoscopy actually helped in the surgeon in performing a colonoscopic polypectomy. Now, the aim of our study and presentation is we just reviewed our experience with the use of intraoperative colonoscopic polypectomy, and also how laparoscopy aid in intraoperative colonoscopic polypectomy. So this was a retrospective analysis of our data in patients seen from March 2001 to September of 2009. There were 106 patients. Included in these studies were patients that were referred by the GI doctor for a benign polyp or a sessile polyp, which was difficult to remove, and also for very large polyps. At times, they referred some of the patients to us because they were not able to adequately visualize or have access to the polyps. Patients with known or suspected malignant tumors were excluded from this study. So all the procedures were performed by two surgeons using similar techniques. Typically, we start by doing the colonoscopy. and then with minimal insufflation, and laparoscopy is added as needed. And we obtain frozen section after the polypectomy when there's high suspicion of cancer. Colectomies were also done for patients that we suspected that they have cancer, or when we did an incomplete polypectomy. Now, at times we might actually start by doing laparoscopy, and after reviewing the endoscopy's notes, if we feel like the patient's polyps were not accessible because maybe it was hidden like at a hepatic flexure, and if the patient has had previous surgeries and we think it's because of adhesions, we might actually put a scope in and try to mobilize the bowel before we do a colonoscopy. So in our results, there were 54% of the patients were male with an average age of 65, and the average size of the polyp was 3.5, which ranged from 0.5 centimeters to 8.5 centimeters. So most of the polyps, about almost 60% of the polyps were located from the hepatic flexure and proximal bowel. We also had some fair amount, about 21 patients with polyps in the rectum, but most of these polyps in the rectum were actually in the upper rectum. And so we performed colonoscopic polypectomy in 63 patients, which is about 59% of the patients, and another 11% of the patients had laparoscopic assisted colonoscopic polypectomies. And 30% of the patients had lap assisted bowel resection. Now for the patients that actually had bowel resection, 17 of them, the resection was done it was a colectomy done. That's the right transverse colon or left colon resection. Cecectomy was done for 7 patients, and 6 patients had transanal excision of polyps. These were actually lower polyps that were low in the rectal wall. We also performed 2 low anterior sections. What happened here? I'm not even touching it. So the complications, we had minimal complications, 3.9%. For the colonoscopy group, there was a patient with bowel perforation. This was a patient that had a cecal polyp that was resected without laparoscopic assistance. He went home and returned to the hospital later that evening with abdominal pain, and radiographic studies showed free air. He subsequently underwent a laparoscopic resection, cecectomy, and did well and went home. Another patient had rectal bleeding, but he didn't have any surgical intervention or any blood transfusion. For the bowel resection group, one patient had an anastomotic leak, which was managed by percutaneous drainage, and there was also one patient with a wound infection. There was a significant difference in the length of stay between the 2 groups, that is the patients that had colonoscopic polypectomy with or without laparoscopic assistance, compared to the patients that had resection. Most of the patients that had colonoscopic polypectomy went home the same day or the following day. Meanwhile, the patients that had resection went home within 5 days. So in conclusion, in our series, about 70% of our patients with benign polyps actually avoided the bowel resection. And this is not what we typically see in in the community because most of the patients that refer to community doctors always have a resection. So laparoscopy can actually aid in colonoscopic polypectomy for difficult polyps, the ones that even if you're an aggressive surgeon and you try to take out the polyps with just using the colonoscope, at times it still gets very difficult. So repeat colonoscopy should be considered on all patients with benign polyps. And in a fair number of institutions that I know, most colorectal surgeons actually perform their own colonoscopy. The limitations of this study, of course, it's a retrospective analysis, and which we just look back at the data, and also just 106 patients. Thank you very much. I'll get some questions.